Peggy, on the measurement side, of course, NCQA has measured quality for years. This area of cost and efficiency is an area that you're involved in, and it's receiving quite a bit of attention.
We've got all the scars.
Yeah, I mean, but to Austin's point, transparency is key. So what can you tell us about where we stand realistically in terms of, you know?
I actually think that the change has to come through the payment model and holding the system accountable for the quality, not through the quality measures driving people to more efficient providers. We've spent years doing, we're collecting data on relative resource use for chronically ill populations. We see very, very big variations on what it costs to give excellent diabetes care in different health plans around the country. But people don't really know what to make of that. They don't know what to do with it. And so, you know, it's kind of informed a lot of research, but it really hasn't changed the market. So I really think that once you have the right payment system, and by the way, I believe in aligning the patient's incentives as well with the provider's incentives. So if Medicare is going to use PCMHs and ACOs, why not give an incentive to the patient to go to those, especially if they are high-need patients that are going to do better? I think that alignment is actually the right thing to do.
So that new Medicaid, next generation model, supposedly is going to allow for that.
Exactly. That's great.
But how much of that variation that you just mentioned for diabetes care in terms of episode cost or pricing is due to utilization differences versus market pricing differences?
It's utilization, because we standardize the prices. That's another reason people find it kind of odd, but that's the way it is. It's utilization, but utilization is not a fact of nature. Utilization is a behavior of the delivery system, right? And oftentimes it's inappropriate, and it's disquality, actually, when you have too much utilization. So
on the utilization side, I'm wondering if any of you have thoughts on the Choosing Wisely campaign and how that's played out. You know, it seemed having specialty societies come up with lists and, you know, acknowledge publicly that there are things that are done that often shouldn't be done.
some of them are good.
That's what I've heard, and some of them
Some of them are not good.
Not. Anybody want to expand on that?
Well, I think it's a remarkable campaign. I actually think that it was kind of surprising. Maybe I'm too cynical, but I was actually surprised that these specialty societies were willing to put these lists together and really and make a big splash about them. I mean, they didn't just sit back and say, well, yeah, maybe you shouldn't do that. They're really pushing it in their own communities as well as for all of us in the public. So that's a good thing. I think it shows that there still is a sense that medicine has a higher purpose than money. That's a really good thing. So I was very pleased with it. I'd like to see them go much farther. I mean, what they focused on were tests and preventive kinds of procedures that are not the big money. The big problems are
colonoscopies are big money.
Well, that's true. That's true. That's true. But I mean, like spinal surgery, C-sections. There's a long list of very significant procedures that they did not address, and so I think that's the next step. Also, it's not really measurable, so we really don't know yet how much progress has been made in Choosing Wisely, so I'd like to see some effort to measure it.
Our PSA measure, I think that's in Choosing Wisely. I think we turned that into, we have two things that we were able. The problem with measuring with Choosing Wisely is that you have so many exceptions that it becomes a chart chasing exercise just to have a measure, so not practical.